So I think one thing also that we are doing more and more, and I think maybe it has not spread to the community yet, to do it routinely, doing a biopsy and genomic analysis for sequencing of the tumors. No. But I think, there is a cohort of patients that would be best treated with an mTOR inhibitor. And that probably is like somewhere around 5 to 10% of those patients who have mutations in the mTOR genes, TSC1, TSC2, P10, PI3 kinase, etc. Those patients with these tumors that harbor these mutations, if I have access to doing a genomic analysis on that tumor and patient agrees to have a biopsy right at the time of progression, that biopsy and that information you gain from the sequencing would be very informative and will help in the selection of your subsequent therapy.
Unfortunately, it's not an all or none phenomenon, though. So not all people with TSC mutations or TORC mutations benefit. Or,
but if they do have that suggests that I think an mTOR inhibitor would be, what I would do next.
And that's important because the two trials that trial that used the sequencing of sunitinib and
Record 3.
Do you want to talk about the Record 3 trial?
Yeah, the Record 3 essentially they used some of that information to select some of the patients that responded very well to everolimus. The group from Dana-Farber did that, suggesting that these mutations you mentioned may actually be more prevalent in the patients with a very good response. But the results were in retrospective analysis, a small number of patients. We need to confirm and validate this data. And also the Memorial Group also showed, using a similar set of patients, some genes that are associated with better benefit for sunitinib, some that may be better associated with more benefit from everolimus. So those are important information that we need to address. And the issue of the biopsy at the time of progression is another important thing, because most of the clinicians do not feel it's not in our regular clinical behavior. So I think that tumor DNA, circulating DNA, is probably one of the things that is being explored in other diseases and that should be explored in this situation in order for us to try to discover biomarkers more appropriately for resistant mechanisms.
The bottom line at the moment there is that we don't have useful predictive tools to allow us to make these decisions.
Definitely.
And I think, when we're in a situation where we haven't got the tools that enable us to select a first-line treatment.
Definitely.
Expecting, hoping to have tools that will allow us to make second-line decisions when one will inevitably have multiple resistance pathways is a really big ask, and we're a long way from doing that at the moment. The other point that I wanted to make is that given the overall survival readouts from the sequencing studies, I tend more often than not to go TKI rather than going TKI mTOR in the absence of everything else, given the overall survival signals that we've got. And then finally, you mentioned an interesting question about treatment withdrawal. So there is a colleague of mine, Janet Brown in Leeds, is running a large 1,000-patient study looking at treatment withdrawal. So standard of care, whether it's with pazopanib or sunitinib, versus treatment until nadir, and then you withdraw, you wait until progression and re-challenge, and you keep going around that loop. And it was powered as a health economic endpoint, because there are obviously health economic implications, but also quality of life, major implications for patients. And certainly we've had some patients who I was expecting to progress once their disease had stopped, once their disease had shrunk and they were withdrawn from treatment, and they haven't. And so if we can more wisely use the tools that we have, it may be that we improve patient outcomes and patient experience.
We need to be creative in order to get around this kind of thing. But in clinical trials, there are two things that I think uniformly we have not been able to collect appropriately and that have a significant impact on the results. One is material at the time of progression, to find out and address all this complexity and heterogeneity in order to inform our future research. And the second, we have not been able, and this is very important in some of the trials, we have not been able to collect adequately post-progression therapy. We need to recognize that patients after progression are receiving more and more lines of therapy, and that has an impact in survival. Okay, and if we do not collect that information, we're not going to be able to appropriately analyze the differences that we have been seeing.
So I think those are key messages. You know, we don't have any valuable biomarkers that are reproducible to help us choose the therapies today, but we do need a lot of research to find those biomarkers. It could be that these drugs are both they're all anti-angiogenic agents, and so maybe it's not very helpful. But now with newer drugs coming out, maybe there's significant, substantial differences in mechanism of action where a biomarker might actually be helpful. So let's move on to that.